So I took a really long break from learning because I think I was really disturbed. And it just sometimes I really struggle with consistency of learning and consistency of teaching because I think I'm still learning how to be consistent. So I guess it's okay. So we trying to get back to learning. So this is the first topic after a while, maybe after in 10 or 15 days. Okay, so we will be studying important basic heart failure points. Note that all of the abstract is from Mehelman, and I think I love his abstract because his his information is on point, and there are not a lot of garbage information, around. There's not a lot of garbage information in this PDF that was provided to me by this website of Mehelman, that is High Yield Cardio. So check them out, check Mehelman, and let's read that out, right? So one of the first important heart failure. So what is heart failure? In simply, when I say heart failure means that when heart is not able to pump the blood. Okay, so that is heart failure. That's it. In easy things. Okay, some problem is happening inside the heart. Maybe it's myocardial problem, maybe it's some sort of electrical problems, or maybe there's a problem of maybe a lot of fluid is there, or maybe you have some sort of you have something wrong, and the result is that you're not able to push the volume of the blood, right, as you were able to do it before. So that's the basic idea of heart failure, right? So basic heart failure. So first is left heart failure. So I want you to understand something. This is your lungs right here, lungs. This is your right heart, right? This is your left heart, right? And this is your body, okay? Right there's your body. So left heart pushes the blood to the body, and then body uses the oxygenated blood and uses the oxygen from the blood inside the body, and pushes the oxygen inside the tissues. And this pushing of oxygen from the blood in the body tissue is called, it's simply simple diffusion. Okay, there is no ATP used in this process. And after the body has used the blood becomes deoxygenated, and it goes to right heart, and then right heart pushes the blood again to the lungs, and then this deoxygenated blood becomes oxygenated blood by the help of lungs, right? And then we get the blood back into left heart. So that's how normally it is done. Okay, so if we have problems in the left heart, right, if the left heart is not able to push the blood to the body, then we have left heart failure. Okay, so that's the idea here. Okay, so let's read it. So it presents as pulmonary findings mean lung problems, right? Lung findings. Pulmonary edema means we have fluid that is leaking from the capillaries into the interstitial fluid. That's edema for you. We have dyspnea. It means the person is not able to breathe normally. We have orthopnea. We have paroxysmal nocturnal dyspnea, right? So paroxysmal means sudden, right? Nocturnal means night, and dyspnea means he's not able to breathe, right? So in the night, the person is not able to breathe as well, right? So that's the features of left heart failure. What about orthopnea? Well, I've written here, orthopnea means breathing problems while laying flat. Now why? Because when we lay down, the preload, as the blood moves more in the thorax, right, preload increases, right? Preload is the amount of blood that the heart has to push. Okay, it's the pre-existing load that the ventricles the ventricles have to push. Okay, so that's the preload, and it's the failure of heart, right? And imagine your heart is failing, right? And you lay down. Now once you lay down, the amount of blood in your thorax region, it increases because of the gravity, right? And once the amount of the blood is increasing, the failing heart is not able to cope up with this increased amount, right? So the failing heart can't tolerate it, and we have serious dyspnea when the person is laying down. So orthopnea is called orthopnea. Okay, so the patient sleeps with many pillows, right? The pillows are right here, the head is here, chest is like this, it's not flat, right? So that the blood flow is normal. So we don't want a lot of blood accumulating in the thorax in this patient. So that's the idea right there. Now let's read it more. PND, paroxysmal nocturnal dyspnea. PND, why it happens in night? Well, when we lay down in the night, the blood comes back to the thorax, and that's why the lung function drops because the right heart, right? Okay, so here's the idea. This is the lungs, this is the right heart, right? This is the body, right? This is the right heart, this is the left heart, this is the lungs, this is the body, right? So left heart is failing, right? It's not able to push this. So if the left heart is not able to push the volume will go back and back up inside the lung. Now right heart has to work more because of the more volume, right? Because a lot of volume is being accumulated due to the failure of left heart, right? So left heart will compensate against right heart will compensate against left heart. So that's the idea, okay, right there. Okay, now this is because left heart problem causes backup pressure onto the pulmonary circulation, lung circulation, leading to increased pulmonary capillary hydrostatic pressure. Now what is this hydrostatic pressure? By the way, hydrostatic pressure is the pressure which is generated by Starling forces. Now what are the Starling forces? It's just that we have two atoms and they're either communicating with they're communicating with each other, they want to talk to each other, they want to stick around with each other because they're friends, right? So I mean, Starling forces in nutshell. So in nutshell, it's just how fluid moves across the capillary walls, whether it leaves the capillary or enters back into the resorption, right? Now we have four types of Starling forces. Starling, right? Cool name, by the way, right? I love this name. Now we have this something called as capillary hydrostatic pressure, or whatever you want to call it. I call it P small c, right? Then now this, what is this, by the way? This is capillary hydrostatic pressure, right? Now the blood pressure inside the capillary, it pushes out the fluid, right? And it is highest at the arterial end, okay? It is highest there. What about other things? We have other things as interstitial hydrostatic pressure, right? It's interstitial, right? Interstitial means it's a pressure in the tissue and it's usually low, and it pushes the fluid inside the capillary, okay? And it opposes this, it opposes the filtration, okay? Now we have oncotic pressure. I mean, in short, what really happens is that we have a lot of fluid accumulating inside the capillary, and this capillary is not able to handle this fluid, and then fluid leaks out. This capillary barrier fails. Usually there's a margin of around 17 mm of Hg, I think. I mean, this is how much more the fluid can be controlled inside the capillary. But here the capillary are failing. Once the capillaries are failing, the fluid will just move out. So that's the idea here, okay? So transduction of fluid into the alveolar space, right? Pulmonary edema. Sometimes this can also cause pleural effusion, right? Now let's read about it. What is pleural effusion, right? Let's try to understand about the difference between pleural effusion and pleural edema. So pleural edema, this is the water, right? Edema in the interstitium, and it causes suffocation. Blood pleural effusion is the fluid in the pleural cavity. Now it's not inside the tissue, it's the okay, so there's the lungs, right? I'm gonna make this is the lungs, right? This is my pleural cavity, right? And we have this one more layer. Okay, I'm just trying to give you an example. So lungs cavity, right here is the water, okay? If we have edema, then we have water inside the interstitium of the lung, okay? So that's the difference right there. So if the interstitium is compromised, you will be suffocating because your lungs are not working anymore, right? You have less transfer of oxygen into the blood, and then less transfer of CO2 from the blood inside the lungs, right? This whole thing will be messed up because we have edema inside the lungs, right? But in this pleural, in this, wait, let me, once we have pleural cavity problem, right? When we have pleural effusion, this lung cannot expand well, and so this will be like a restrictive, type of problem. Okay, it's restrictive. It's restricting the the lung from opening up and closing, right? So that's the idea right there. Let's try to understand more. In left heart failure, the left atrial pressure, that is LAP, left atrial pressure. Try to understand it. we have left heart, right? It has a atrium and a ventricle. Usually ventricle is way bigger than atrium, but I just made it that way. So this atrium pressure goes up. Why it goes up? Because ventricles are failing. That's why. If these are failing, of course this pressure will go up. Okay, so here the author says that LAP increases and pulmonary capillary wedge, right, it also increases. Now this pulmonary capillary wedge pressure, PCWP, is a cool thing. Why? Because increased PVP equals to more blood in the atrium, but ventricle isn't pushing the blood, and then blood backs up, and then we have increased pulmonary capillary wedge pressure. Now what is this pulmonary wedge this pressure thing, right? What is PCWP? Let's try to understand that. Now it's a window into the left atrium. Okay, we push a Swan gang catheter via right heart, right, and then we push the catheter through the pulmonary artery branch, and then this wedge tip block the forward flow of the blood. Now once this tip has blocked the forward flow of the blood from the pulmonary from the pulmonary artery, right, or we can block the blood from the pulmonary vein as well, but I think we're going to block it at the pulmonary branch, right? So that pressure on the left atrium is PCWP. It's not synonymous. It's just that we can understand it. It's not really accurate in terms of it's not the real pressure inside the atrium. It's just we are trying to take a look in the left atrium, right? So that pressure in the left atrium is PCWP because there is no valve from pulmonary vein to left atrium, right? So in stable patient, PCWP can be equal to LAP because there is no communication, right? So this is my left okay, wait, let me make it. This is the lungs. Okay, imagine with me. This is my heart. This is my right heart, right? This is my right atrium. This is my right ventricle. This is my body, right? And so here's the concept is that we have this, pulmonary vein, right? This is the pulmonary vein. And there is no valve here. There is no valve here. So this is communicating directly. So we can think that this plus this vein is one chamber. We can imagine that because there is no blockage, right? So there is no valve from pulmonary vein to left atrium. So in a stable patient, this PCWP, that is pulmonary capillary wedge pressure, can be equal to this left atrial pressure. So that's why PCWP can be used to understand the left ventricle, problems, right? So we can use this PCWP as left ventricle end diastolic pressure. Okay, so that's the idea here. Okay, conversely, okay, therefore if there is left heart pathology, PCWP is high, right, exceedingly high, really high yield. Conversely, if the question gives you a normal PCWP, it means there is nothing wrong with the left heart, of course. The question will give you high PCWP and a low blood pressure. Now low blood pressure, right, where you need to know immediately that this means cardiogenic shock. Now we'll talk about it. Why? Because low blood pressure plus increased PVP is cardiogenic shock because our heart is not pushing a lot of volume, right? And that's why we have low BP. And then we have increased PCWP because we have some sort of increased pressure in the left atrium, and that suggests left ventricle failure. And that also communicates well with low blood pressure. So that's why we have cardiogenic shock right there, right? I hope you understand that. Now, what USMLE wants you to do is give you some sort of left heart pathology and dyspnea, and then ask for the cause of dyspnea, right? And short answer is increased pulmonary capillary hydrostatic pressure. Another answer is the case of increased alveolar arterial oxygen gradient. So really simple, how it happens. So increased AA oxygen gradient. Now how much O2 is available and how much is dissolved. That's the gradient for you guys, right? So alveolar means how much O2 is in the lungs. Arterial is how much it can take, right? And this gradient is increasing, right? If this gradient is increasing, it means the conversion, right, from oxygen into the blood and this carbon dioxide into the lungs, right, it's very bad. So due to that, this gradient is increasing, right? This gap of this gap is increasing basically. So increased gradient is due to increased edema, and it's due to alveoli filled with blood or pus or whatever you want to call it, and it's poor O2 diffusion, and then partial alveolar oxygen is normal, but partial arterial oxygen levels, they go down. So gradient is widened, right? So I hope we are able to understand this common and a very simple information, right? So that was for you left heart failure in nutshell.